There's a lot of complexity in terms of the different biological, physiological changes due to aging, the way that aging affects the disease process itself, and then also how we then, measure this.
They all have the same problem, that there are age-related changes which are difficult to disentangle from the MS-specific changes that occur.
You can see that by the age of 60, 70, about 92% of people with MS will have some degree of cognitive impairment, and that the main driver of this is actually the age itself, not disease duration.
Somebody's been on a drug, let's say, for 20 years, and they're now in their late 50s or perhaps in their 60s. Can you reduce the dose, or can you reduce the frequency of the dosing?
Hi, my name is Anneke Van Der Walt. I'm a neurologist in Melbourne, Australia, and I am the director of MS and Neuroimmunology and Neuro-ophthalmology at Alfred Health in Melbourne, and I also work at Monash University.
Hi, I'm Frederik Barkhof. I'm a neuroradiologist working at Amsterdam University Medical Center and also at University College London in the UK.
And I'm Brett Drummond. You're listening to the ECTRIMS podcast, the official podcast from the European Committee for Treatment and Research in Multiple Sclerosis. While MS was traditionally described as a disease of young adults, the significant improvements in treatments over the past few decades has meant that researchers and clinicians are now increasingly handling questions related to the impact of aging. How does the disease change over time? Do certain symptoms worsen? Do treatments become less effective? My guests in this episode, Frederik and Anneke, were recently involved in a large international workshop that focused on aging in MS, which we will be discussing today. Frederik, Anneke, thanks for joining me.
Thanks for having us.
So as I said in the intro, there was recently a workshop held, including participants from around the world, to discuss aging in MS. Can you talk to us about this meeting, who was involved, and why was it important?
Well, we are members of the International Advisory Committee on Clinical Trials for the National MS Society, who is a committee of international MS clinicians and scientists who come together and look at areas of need in multiple sclerosis research and in clinical practice, with the purpose to look at better ways to design clinical trials in areas of need. So the topic of aging in MS and how that's managed came up as a suggested topic. And that's really where this all started. And as we started to scratch the surface of this, we started to realize what a huge need there really is to try and generate better evidence and understand both the biology, the clinical presentation, the disease progression in people who are older, and also, the very careful balance between risks and benefits of treatments that has to be considered in people as they either, develop MS at an older age or age with MS, and how we can, the challenges that we have to try and make these trials better. So that's pretty much where it started, and we came together in Philadelphia with a whole range of experts talking across a range of all of these different topics to try and work out an action plan on how to move this field forward and come up with ways that we can better help people in this situation.
Fantastic. So I think one of the things that you mentioned there is interesting. We're going to go through the spectrum, all of these things across the episode. As I mentioned in the intro, we traditionally think of MS as being a disease of young adults. We probably have all heard the statistic that around 70% of people get diagnosed between 21 and 40. But you mentioned there that one of the focuses was around thinking about people who get diagnosed later in life. Are there certain challenges that arise when trying to diagnose MS at an older age? Frederik, maybe I'll start with you for this question.
Yeah, that's an interesting question indeed. So the panel that Anneke mentioned, they focus on trials, but actually they organize quite a few other meetings as well, including the diagnostic criteria that we use, the McDonald criteria. So this same group also organized the revision of the McDonald criteria, which will be released later this year. And indeed, diagnosis of MS at an older age comes with a set of problems, because unfortunately, as we age, our brain changes and we develop other diseases, especially cerebrovascular disease, which may manifest as little spots on the brain scan, which may look superficially like MS. but also other diseases may develop at older age, which may mimic the clinical signs and symptoms of MS. So diagnosing an older patient with MS is more challenging than in a young person where you're unlikely to find too many other types of diseases occurring.
And so I guess throughout the meeting, what was discussed around how we might be able to address some of those challenges?
Well, I think one of the big things, if we're talking specifically about people who develop MS at an older age, I guess firstly to say that we would consider this people who develop MS at an age older than 50. And we know that this is actually a small group of people. So it involves about 10%, 5 to 10% of the overall, group of MS patients in most registries, for instance. And I think the first thing to note is that a lot of people that are diagnosed at an older age are diagnosed late. So there's a diagnostic delay. And the reason for that is often because it's more likely to present with progressive symptoms. So the majority of patients will still be relapsing, remitting, but there is this sort of sense that progressive presentations are perhaps a bit more common. And as we know, those are much harder to pin down sometimes and diagnose, and they often take a bit longer to come to the attention of medical practitioners. Then the second issue is, what Frederik was mentioning, in that the typical test that we use, which is MRI, and we heavily rely on that, could be much more likely, dismissed as, small, deep white matter ischemia or chronic small vessel disease in older people, especially if they also have, comorbidities, like hypertension and diabetes, or they're smokers. And so it becomes a bit harder to diagnose that. So what the committee was really looking at is, ways to raise awareness around the possibility of developing MS at any age, the clinical presentations of this, and trying to find better ways to interpret imaging, when we do imaging of people at the older age. And I think Frederik works in, obviously, as a neuroradiologist, has much better, understanding of what's needed to move the field forward, especially as we're talking more and more about AI pipelines that are analyzing lesions. And the fact that many of these have not been validated in older people. But I'll let Frederik talk a bit about that, because, that's obviously a huge area, a gap in our knowledge.
Yeah, thanks, Anneke. As you said, MRI has been very helpful in supporting the diagnosis and ruling out other diagnoses, but it's increasingly difficult at older age. So the McDonald criteria, the 4 regions that we assess, or it will be 5 regions in the future, are obviously chosen to have specificity. The periventricular lesions may occur in older people by coincidence, and even infratentorial lesions, for example, central pontine abnormalities, are common in people with hypertension. So the thing that is really very specific for MS and remains specific for MS at older age is spinal cord lesions. Because with hypertension and aging, you may develop incidental brain lesions, and some people develop hundreds of them, but they won't have a single lesion in their spinal cord. So finding multiple short segments spinal cord lesions is very specific for MS, even at older age. So I'm always a fan of spinal cord imaging. I think it's always good to do that in the diagnostic setting, also for the prognostic relevance, but especially at older age, I think it's almost mandatory to do it. And as you said, Anneke, often, these people may have a more slowly progressive presentation and some more primary progressive type of presentation, and you may want to rule out a compressive myelopathy at the same time. But even in the absence of it, I think it's very important to do spinal cord imaging.
So shifting back to the other group, which is talking about people with MS and the processes that they go through while they're aging, a number of questions I want to ask around this, but maybe if we start with how their experience changes over time. What do we know about how their symptoms change as they get older? Are there specific things that get worse, different things that come into play? I know cognition is obviously something that we talk about a lot as being something that becomes increasingly problematic as a person ages in the healthy population as well. But, how does that change in a person living with MS? What do we know in that area, if much?
So as people age with MS, I guess I'll just take a step back and say that, age really is the major determinant of, how MS presents, how it progresses. It also is a major determinant of the plasticity and the remyelination capacity of the brain. And then, of course, the way that MS responds to disease-modifying therapies change as people age as well. So there are several things to consider there. So, but if your question is around specifically, symptoms that people could experience, I guess the main thing to note is obviously as people age, they are more likely to have, longer disease durations, which is associated with progressive disease, of course. So it's, more likely that people will start developing, like or have the presence of mobility problems, ambulation problems, bowel and bladder dysfunction, as well as, cognitive problems, which you mentioned as well. And there's several, studies that, clearly shows that, the main driver of increased cognitive impairment in people with MS is actually age. And you can see that, by the age of, 60, 70, about 92% of people with MS will have some degree of cognitive impairment, and that the main driver of this is actually the age itself, not disease duration. So, so it's really sort of it influences symptoms in a very, very specific way. And I think one of the key things is to be aware of the accumulation of problems that people have as they age, and the fact that the response to treatments that we would usually consider very effective might not be the same, and that symptomatic treatment of common MS symptoms is more challenging because of the presence of other comorbidities. So you have a higher risk of polypharmacy, for instance, where people could be on multiple drugs with interactions and side effects as well, which is often that impacts on someone, and someone might suddenly not tolerate a drug that they've been on for 5 or 10 years. So I think, we have to, take a very holistic approach, to people's symptoms and also their disease activity.
Yeah, and to add to that, so we had a whole session about monitoring MS severity. So we were reminded of a study that did a double-blind assessment of healthy controls and MS patients over the age of 55. And interestingly, the healthy controls, there was not a single person with the EDSS score of 0. And in fact, I think the average EDSS score over healthy controls over 55 was almost 3. So just to remind you that especially the functional system scores, but also other elements of the EDSS are influenced by non-MS pathology. And I think the same holds true for imaging. If you look at lesion load, some of your lesions will be, even if you have MS from an early age on, you will develop some vascular lesions alongside. So it's very difficult to determine if lesions accumulate, whether some of those might be due to hypertension, for example. And the same thing holds true for brain atrophy. With aging, we lose a bit more brain volume, and that accelerates slowly. So the relative contribution of MS-specific atrophy declines with time. And similar effects occur with OCT, NFL, GFAP, so blood biomarkers. They all have the same problem, that there are age-related changes, which are difficult to disentangle from the MS-specific changes that occur.
Yeah, and so delving into that a little bit further, I think we all know that MS is a particularly complicated disease to try and understand. And as a person ages, we're trying to understand what is MS, what is aging, and what is aging with MS. I think there are 3 different factors that are contributing to this, which obviously make it really difficult. Do we know much about how disease mechanisms change in terms of the biology, the pathophysiology of what's happening there, and how do we disentangle these three combining factors?
Shall I give it a shot, Anneke? Yeah, so we had very good neuroscience talks, but I can only summarize them at a high level. So there are all sorts of changes that occur with aging. So, the regenerative capacity of the brain declines. For example, oligodendrocytes are not as well able to remyelinate at an older age, and neurons and axons become more vulnerable. At the same time, the immune system changes. There's something called immunosenescence. So the immune system slows down, has less adaptive responses. But it's not completely asleep, so it's still able to do something, but it's less agile. And for this reason, for example, we need to make sure that we do better prevention of infections, for example. So I think there was quite a bit of discussion around more active vigilance of vaccination status. As a practical example, just to make sure that all the patients are vaccinated and have appropriate infection control. But perhaps Anneke, you want to add to this?
Yeah, I think you sort of covered a lot of what was discussed. I mean, it was very interesting to think about the concept of chronological age according to your date of birth, and the concept of biological age, and that in people with MS there is extensive, evidence from different cell types and also tissue samples that what we're dealing with is accelerated aging on multiple levels. And as Frederik said, this has impact on the brain's capacity to repair. And one of the interesting, I guess, markers of this is also genetic. So having a look at telomere lengths, for instance, this is very strongly associated, shorter telomere lengths with a higher biological age. And so I guess that's sort of one particular biomarker that's of interest to try and assess someone's, biological age. And the other things is also to think about the different immune cells, and that T cells, B cells, the function of these cells change as we age as well. And that has implications on how the disease presents, and how it also, progresses, and how it could be treated. Because I guess what we see is very much like less inflammatory, focal inflammatory activity, which of course translates into less relapses as people age, and less gadolinium enhancing lesions, for instance, as well, which of course is challenging in a clinical trial situation where we often rely on these things. But at the same time, we still have, this compartmentalized inflammation, which could be, contributing to progression, for instance. And as we know, that's particularly difficult to measure. So there's a lot of, complexity in terms of, the different biological, physiological changes due to aging, the way that aging affects the disease process itself, and then also how we then measure this, as Frederik was saying. So, yeah, it's very difficult to entangle, but what was very clear is that we desperately need to understand the usual biomarkers that we use, the usual outcome measures. We need to understand better how they perform in people aging with MS.
Just to add to this, Anneke, you rightfully said that overall people at an older age are slightly less likely to have relapses and slightly less likely to have gadolinium enhancing lesions. But that's the average. And as you said, there's quite a bit of variability in how people age. Some people age very successfully, other people age prematurely in multiple aspects. And this is also true for the inflammatory response. Even the other day, we had a patient manifesting for the first time in our MS clinic in Amsterdam. And they had about 20 enhancing lesions on their brain scan, and the person was over 60. So there are individuals who still have a very active inflammatory response, and others may have not. So I think you need to make the assessment in the individual patients rather than to work from these generalizations.
I absolutely agree with you there, Frederik, because I think we, sometimes we, in our heads and in our minds, we might have this picture of an older person, must have progressive disease, must have less inflammatory activity, but that's actually not true. So if you look at the registry data, and there's a flurry of publications this year on this, is clearly a hot topic. But it consistently shows that most people who develop MS at an older age present with relapsing remitting disease. And they still have, even though it's lower than people who present at a younger age, that patients still have a higher relapse rate, than people who have aged with MS, for instance, who's had a longer disease duration. So there's still that window of opportunity. And I think we do have to think about that even though, we know that the inflammatory activity drops off much faster, and you may have someone that you'll start on treatment, but you may not discontinue it for decades. But you still need to try and target the inflammatory activity as much as possible. So it's certainly important that we paint that picture of that most people still present with inflammatory activity and relapses.
And I guess that's important when we think about treatment effectiveness and how that differs over time, and actually bringing up another point that I want to tie into that. Anneke, you're probably really well placed to answer this. So how does the treatment effectiveness change over time, but how critical has the introduction of these large international clinical databases, such as MSBase, for example, been in terms of our ability to really understand what's happening to a person MS over time?
Look, they are very valuable because they provide, often quite a longitudinal perspective on, very large groups of patients. So it is possible to have a look at, for instance, subgroups of MS, like people who present at a later age or a very late age or over 60. And then to develop comparative analyses using, propensity score matching techniques to try and understand, the efficacy of an intervention like a high efficacy treatment, and how that actually, changes potential relapse rates, disease progression, and so forth. So, we just published a paper just recently in JNMP looking at the efficacy of ocrelizumab in people older than 60. And you can still see that it still has a significant benefit in terms of reducing annualized relapse rate. But in the study, the average duration of follow-up was only about, I think, 2.5 years, if I remember correctly, and we didn't see an effect on disease progression, for instance. So these registries are very helpful in that regard because, these are clinical trials that are very difficult to design and generally not of interest to pharma. But they always have to be, considered in view of the data source, of course, and also the potential confounders, because it's not the same as a randomized clinical trial. But they, with a careful question and a careful design, and thinking about potential confounders, they often can provide us with very clear clinical, answers to clinically relevant questions. So they can be extremely valuable.
Perhaps I can elaborate on this point. So, you talked about treatment effectiveness at older age. And as we discussed previously, there is an overall decrease in the number of relapses and the number of enhancing lesions. All that may vary from patient to patient, but on population level, there is less activity. So there's also discussion around what is the effectiveness of a drug in this population, where there's on average less to be gained, and on average there's slightly higher risk of side effects or comorbidity playing in. And that's probably also why pharma companies are a bit risk averse. They're risk averse in general, especially in this particular situation, because the treatment benefit to harm ratio is going down. So for them, it's a risk to include all the subjects. So they're often excluded from trials, which is really a pity. And the FDA actually has a policy that they stimulate diversity. Think of ethnicity, gender, etc., but also age. So there's really a role to be played here to stimulate them to include some older subjects, even if it was in a more observational part of a trial. And likewise, I think payers should have more interest in this subject to understand, who at an older age should still be treated. Because, if they are going to pay for a drug, they want to know what is the number needed to treat and what is the number needed to harm, to determine what is the cost efficacy of a drug in an older patient.
I mean, look, it's a hugely interesting topic, and there's obviously a lot that we could cover on this. It's obviously a hot topic at the moment. But to narrow it down to finish off with the last question, for the two of you having come out of the meeting, what do you see as one or two key focus areas for research and clinicians regarding aging and MS that need to be addressed in the coming years? Big question, hard to narrow it down, but give it your best shot.
Well, I guess, my take-home messages from the meeting was firstly that, we're all getting older, our patients are getting older, and more than 50% of people with MS now is older than 50. it is really, really important for us to understand that people living with MS have accelerated aging, and that we have to try and think of strategies to slow that down if we can. And that, at the moment, most of the evidence really point towards exercise being, a good way to do that. But increasingly, there's also a whole field of drugs called senolytics, and other medications, which is could have a big influence in people with MS aging as well. So that's a big field of research. And I think the other big thing for me was the way that we don't understand how biomarkers perform in older patients, and that we really need to understand that, because otherwise we're going to set up clinical trials that'll fail. So I think those are probably the big gaps.
Yeah, for me, I think so. There's a lot of uncertainty about whether to still initiate or to continue treatment. So initiating treatment, I think, you should just apply the same rules as in younger patients. If they have active disease, start treatment. But then there's a lot of discussion. Somebody's been on a drug, let's say, for 20 years. And they're now in their late 50s or perhaps in their 60s. Can you reduce the dose, or can you reduce the frequency of the dosing? And some data were presented. And it looks like, if you're not really old, then probably it's not safe, or at least without careful monitoring. Well, on the other hand, other problems occur. So we talked already about vaccination, monitoring for cancer risks. Some drugs have a slightly increased risk of cancer, so there should be vigilance about monitoring for that. And I think in general, we need more education of physicians treating older patients, probably more education of the patients themselves, empower them, make sure that they're aware of their risks, probably better control of comorbid disease. As Anneke says, be more aggressive in treating cardiovascular risk factors. And interestingly, some of the drugs that people get for cardiovascular disease, think of cholesterol-lowering drugs, perhaps also have a beneficial effect on MS. So they just paints a very complex picture, which probably should involve multiple people, perhaps even geriatricians, and multidisciplinary team efforts, I think, to tackle this.
Thank you for distilling down what was obviously a huge amount of information into a couple of key points. And thank you both, Frederik and Anneke, for your time today to contribute to this podcast. It's been a very interesting discussion. Thanks everyone for listening. Once again, I'm Brett Drummond, host of this podcast episode. I'm also co-founder of MSTranslate, an independent resource centre that aims to simplify the complex wealth of information about MS for the greater MS community. The ECTRIMS podcast is produced and hosted in collaboration with two key partners, MSTranslate and the MS Journal, a peer-reviewed international journal that focuses on MS, neuromyelitis optica, and other related autoimmune diseases of the central nervous system. The ECTRIMS podcast is supported by an educational grant from Roche, Alexion AstraZeneca Rare Disease, and other grant providers. Educational grant providers have no input on the podcast series content. You can read more about the topic of this latest podcast episode and more on the ECTRIMS website, ectrims.eu. Do subscribe to the ECTRIMS podcast on your favourite podcast channels and follow ECTRIMS on X, formerly Twitter, LinkedIn, Facebook and YouTube.